and I'll be talking to you about chronic disease management and preventative health. So obviously this is an enormous topic, and we've only got about 50 minutes, so we'll cover what I think are the most high yield aspects of this topic. So we're covering management and prevention, surprise, surprise. With management, we'll talk about Murtagh's model and how we can use that. And we'll go into some detail with some metabolic conditions and some respiratory conditions, which are very common and I think particularly high yield. Then we'll also talk about prevention, and here we'll focus on behavioral change in terms of smoking and alcohol. And we'll also talk about the big three kind of cancers that we screen for here in Australia and what you need to know about that. And yeah, so we'll talk about management first. There was just so much good content from this interview that I had to sneak it into a lecture. So I hope we can have fun with this and enjoy the next hour. Okay, so some of us will know Murtagh's 10-step management plan. I think some of us have done GP, some of us have not. So I'll give you my take on it. And it's basically a way to give a diagnosis and a management plan to a patient in a way that makes sense. And so the way I remember it is DKA and pre-Fs. And if you manage to pull it off, you will look this fancy. DKA stands for diagnosis. So state the diagnosis. So Mrs. Smith, we've done the blood test and it looks like you have type 2 diabetes. Knowledge, what do you know about type 2 diabetes? Attitudes, how do you feel about having this diagnosis? Education. So this is where we want to explain what exactly the diagnosis is in a way that makes sense to the patient. Now, this is really important because we, obviously all of us know all these fancy medical terms, but to a lay person, it doesn't make sense. And so you need to know how to explain the diagnosis in a way that that you can explain to someone over coffee over a minute or two is how I like to sort of put myself to the test. I think if you're able to do that, it shows that you really do understand the condition. And so I want you to practice that, and we'll talk more about that in a moment. Then we get into the thick of management. So what management plan you have for the patient. And there's a few ways we could, I guess, split this up. And whichever way we do it is fine, as long as we cover all the main kind of area. Then we can go into prevention. So while you're here today, Mr. Smith, I'd like to also talk to you about cardiovascular disease risk or cancer screening or vaccines, etc. While I've got you captive here in my practice today. Then reinforce. So could I ask you to repeat all the main things that we've discussed today? And that's just, you can ask that question to make sure that they've taken it in and that they've understood. Information. So you can go to the Better Health channel and there's a great page on type 2 diabetes that you can read in your own time. Then evaluate. So did we cover everything that you wanted to cover today, Mr. Smith? Follow up. So I'd like to see you again in my practice in 2 weeks' time or whatever. It's usually quite an average, somewhere between 1 to 2 or 3 weeks. And then step 11. So it's technically a 10-step management plan, but Claire Harrison teaches it with some extra steps. And I think this is a really useful one. Is to safety net. So for any warning signs. So, if Mr. Smith, you happen to get some sort of chest pain or dizziness or something, and you're worried about it, then you can see me sooner than the 2 weeks. Or if you're really worried, you can head straight to the emergency department. So I think that's an important step to state. All of these will need to be done in an OSCE, but obviously the bulk of the marks are going to be in management and prevention. And hey, presto, those are just the things we're talking about today. So that's perfect. Okay, so what I just went through there in that last slide, I think you should be able to do at a basic level for all the main big ticket items across all the systems we learned in year 3. And there's no, I guess, right or wrong way to go about this, but I just went through the whole year 3 matrix and went, okay, what are the big ticket items in each system? Here's what I came up with when I did this brainstorm, but you may very well come up with something different. So I want you to do this in your own time. And hopefully between you and I, we come up with all of them. This is what I think you should know in the sense that they're common enough and tested enough in OSCEs that you should know about them and know what the broad senses of management are. And, you don't need to go into massive detail with, I think, any of them, but as long as you know the key points of management and how you'd state that to a patient, I think that's the main thing. You also need to be able to explain all of these in patient-friendly language. As an example, I gave a 30 acute a few days ago, and we talked about epilepsy. And it's no use talking about epilepsy as cortical hyperexcitation to a patient because this makes no sense whatsoever. And so we talked about an analogy with traffic lights and suddenly all the traffic lights go green and all the cars go and start crashing. And we described a seizure in that kind of way, and that's a way that makes sense to a patient. And so I want you to think about how you might explain all of these things to a patient in a way that actually makes sense. Not just think about it, but actually practice it with friends as well to make sure you can actually do this, because you will be put to the test in an OSCE. I haven't brainstormed through PED, Psych, and ONG because there are obviously all the other things you do this year. And Opthal and ENT, I feel like are a bit more diagnostic style of OSCEs rather than a 10-step management, but you should know all of them as well. And hopefully you'll be big brain by the time you finish this. Okay, oh snap. So this is, of course, we're talking about smoking, nutrition, alcohol, and physical exercise. If we do all of them, we'll be big and strong like Michelle Obama. So smoking is a behavioral change thing, but there's other things we can do as well, and we'll talk about that in a sec. Nutrition is eating across all the 5 food groups in the pyramid, including 2 serves of fruit and 5 serves of vegetable every day. Vegetables of different colors are even better. The person to refer to for this would be a dietitian. Alcohol, so cutting down on alcohol, ensuring you're less than 2 standards a day and less than 4 on any one occasion. And if you're pregnant, obviously not at all. And there's other things we can do as well to help you quit, and we'll talk more about that later. And then physical exercise. And so, moderate intensity, at least 30 minutes, 5 days a week, includes structural as well as incidental exercise. And the person to refer to here is an exercise physiologist. It sounds like I'm just railing all of this off, but I want you to really have particularly these numbers in your head and be able to explain this to a patient, on the fly, because pretty much, SNAP is relevant to, I would say, pretty much anything and just general health and well-being. So this is something you'll commonly be explaining in an OSCE station. So make sure you're able to do that, and hopefully you can do Michelle Obama proud. Let's talk about cardiovascular disease risk. So there's something called absolute cardiovascular disease risk, or absolute CVD risk. I've given you the link there, and you can explore that in your own time. This is what we use for 35 to 74-year-olds who have no existing cardiovascular disease. And it tells you your 5-year risk of developing coronary artery disease or stroke. It's considered low if it's less than 10%, high if it's more than 15, and medium if it's in between that. These are the factors that go into that calculation. Again, I'll let you explore this in your own time. I think it is worth having a play around with. And I guess the point with cardiovascular disease risk is, for the most part, people feel fine, right? They feel completely asymptomatic. In fact, they might even be living their best life, partying every weekend, smoking, drinking, you name it. And so they don't necessarily have a reason to be concerned. And this is where your communication skills are really put to the test in how you explain risk to the patient in a way that they don't completely freak out about it, but at least that they're concerned about it enough to do something about it. It's hitting that sweet spot in the middle. And actually engaging them as a patient. So please try to practice that and practice communicating that as well. Very common OSCE station you could get purely just on cardiovascular disease risk. Let's talk about hypertension on that note. So as we hopefully know, hypertension can be graded based on severity of your blood pressure. And how we management is by and large SNAP. In all the ways we talked about. For secondary prevention, so if someone already has hypertension and you're managing that, you would target a low salt diet of less than 4 grams of salt a day. If it's primary prevention, so they don't have hypertension yet and you're trying to prevent that, then it would be less than 6 grams a day. Very easy EMQ, please know these numbers. Pharmacological management, as you know, there's a lot of antihypertensives, and I won't go through all of them, but what's presented in the Oxford Handbook, for example, is this. So it's ACT. So you normally start with an ACE or an ARB. You trial that for 3 months. If their blood pressure still is not under control, then you can add another one. And the second thing you typically add is a calcium channel blocker of the dihydropyridine class. So not verapamil or diltiazem, which is centrally acting, but the peripherally acting ones. You trial that for 3 months. If that's not enough, then you'd maximize the dose of one of these, and then you'd maximize the dose of another. And if that's not enough, then you would tack on a thiazide diuretic. So it's quite a step-by-step approach, as you can see. And we would never do this in isolation. We'd always do it alongside all the SNAP stuff that we just talked about. There's some other rules. So based on the research, if they're more than 55 or if they're African, we might skip the ACE and head straight to a C or a T, and fine. But another important point, if their blood pressure is still high after 3 drugs, and it's just not going down, then you might want to start getting suspicious for secondary causes of hypertension. Things like primary aldosteronism, which we know can just keep people's blood pressure really high, and all of these things won't really work very well for it. So just know when to be suspicious of that, and so you can actually screen and do something about it so you won't miss a secondary cause of hypertension. This is from the Heart Foundation, and it's just a little kind of flowchart to tell you that you need to factor in both absolute cardiovascular disease risk and the severity of hypertension when you're managing someone's blood pressure. You don't need to memorize this, but just know the principles. Okay, hyperlipidemia. So this is similar, related to metabolic syndrome. So high cholesterol and high trigs can be part of this, and there are some reference ranges. Please learn them. Again, we'd be managing with, by and large, with SNAP. Particularly, the specific thing here is a low SAT and a low trans fat diet. SAT fats are found in meat, fish, and dairy, and so we'd be avoiding them. And trans fats are found in confectionery and processed foods, and so we'd be avoiding that. Pharmacological management. So we'll go to the meme first. So my cholesterol is too damn high. Yes, but it's actually cholesterol and cardiovascular disease risk that has to be too damn high for us to actually do something pharmacologically. How rude of me to edit the meme, but it just had to be done. So we would only treat someone's elevated lipids if their cardiovascular disease risk is at least a medium, if not a high. So it has to be at least 10%. We normally start with a statin, and that has a few kind of side effects. So hence why we don't just give this willy-nilly. It's very commonly causes muscle aches and rarely can cause rhabdomyolysis, but that's super rare. It's hepatotoxic, so you'll have to monitor their LFTs frequently. And paradoxically enough, it also increases their risk of diabetes. And so we don't really want to give it unless we have to. We would trial that for 6 weeks, and if that's not working, then we might think about tacking on ezetimibe, which mostly lowers cholesterol, or even fibrate, which mostly lowers trigs. This is a more kind of physician-y side note. So just know that hypothyroidism can also contribute to elevated lipids. And if the trigs are super high, we'd be worried about their risk of pancreatitis. This is from ETG, as you would recognize the table. It just tells you the target reference ranges for different lipid components in people who have hyperlipidemia. Now, to be honest, pretty much all of these are just the normal reference ranges. So if you know the normal reference ranges, you pretty much will know this. So I'd recommend you know that. Okay, type 2 diabetes. So this is quite a big topic, and I've just come off endo, so I'll try not to be too much of a fanboy about this, but let's see how this goes. OSD risk is what we use for to calculate people's 5-year risk of developing type 2 diabetes, and this is similar to what we talked about with CVD risk. It's just a different tool. The other aspect of screening is not everyone will have type 2 diabetes. Some people will actually have type 1. And how we screen for this is we do their C-peptide, and we do that fasting alongside their fasting blood sugar level. C-peptide is just a marker of their endogenous insulin production. So it would be low if they have type 1 diabetes. Otherwise, it would be normal. And we also do antibodies for IA2, GAD, and zinc T8. You don't need to know too much. Just it would be good to just know these by name, so you can just throw that in if you need to. Okay, but now let's just talk again about type 2 diabetes, get our head back in that game. Again, having been on endo for a while, these are the common kind of treatment targets we would have. And we do modify this based on individual blood sugar levels and so on, but this is kind of our baseline. So these are good numbers to know. We want to target fasting blood sugar levels of around 4 to 7, not less than 4, because that's a hypo episode. Random blood sugars of around 5 to 10, a HbA1c of less than 7%, or if they're a high risk for a hypoglycemic episode. So if they're elderly, for example, and on insulin, then we might run the sugars a little bit high and have a higher target threshold. But these are just kind of the normal numbers we would have for management. You might notice this is different to how we diagnose diabetes, because it's actually that those two are different things. HbA1c of 6.5 for diagnosis, but that's not what we target for management. So just know that there is a difference. The non-farm stuff, we always start with non-farm stuff. That's what being a Monash doctor is all about. So SNAP, as we discussed, it all comes back to SNAP pay, but particularly low GI and a low sugar diet for any form of diabetes. We want them to be checking their blood sugar levels at home with a glucometer. Most glucometers read blood sugar levels around this kind of range, and anything lower or higher than that will show up as a low or high, and so which would be an emergency, and they'd have to come to the emergency department. Every 3 to 6 months, we'd like to review their HbA1c and their blood sugar levels, and I'll talk more about that in a sec. And we can do some clinical measurements as well, just for the general kind of metabolic health. And every 12 months, we want them to be seeing an optometrist for their eyes, seeing a podiatrist for their feet. And we do some extra blood tests to see how their lipids and their kidneys are going, given what we know about the complications of diabetes, and we'll touch on that in a sec. That's all the non-farm stuff. The farm stuff is we normally like to start people on metformin. It's effective. There's not many side effects. It actually does a good job of lowering sugar levels, so we love it. We love metformin, and we give it pretty readily. If that doesn't work in about 3 months' time, then we might think about tacking on extra additional oral hypoglycemic agents, but we wouldn't jump straight to them as a general rule. If nothing else works, or if their diabetes is very severe, we would start insulin, normally of a basal bolus regime. We could give a whole tune on insulin, so I won't go into so much detail, but I'll just say basal insulin, as we probably know, is usually around once a day. It's just for your baseline energy requirements, and as opposed to bolus insulin, which you typically have 15 to 30 minutes before every major meal, before breakfast, lunch, and dinner, for most people who have 3 meals a day. And that's to make sure all that extra carbs you're eating actually gets absorbed into your body and doesn't just stick around your bloodstream. And so we can start short basal bolus insulin if needed as well, but that we don't jump to that. We would only jump to that usually in a type 1 diabetic, where that's like the mainstay of treatment. Now, something I want you to know, which I didn't know until I sort of got into the practical swing of things, is that there are actually laws around this in terms of driving. So if someone's medicated for any form of diabetes, Vic Roads has to know about it, so they have to disclose that to Vic Roads. And if someone's on any form of insulin, for whatever reason, they need to measure their blood sugar levels before they drive, every time before they drive, and ensure it's at least 5. So it's their responsibility as a diabetic to actually do that. And it's good if you can communicate the fact that they have that responsibility while you're giving your management. Okay, blood sugar level monitoring. So to track blood sugar levels, I'm going to make a point here. You need both HbA1c, which tells you your last 3 months or so of sugar control, because that's how long your red blood cells stick around. And again, we all know this from third year, so I won't labor those points. But you also need the blood sugar level to get the full story. Now, I'm so sorry to give you PTSD from maths methods, but there's a reason I'm bringing a picture like this to your screen. So if we imagine that these are two people's blood sugar levels over time, we can see that on average, the average is the same for both of them, right? So their HbA1c would be exactly the same. If you're only measuring the HbA1c, you'd go, yeah, these two people have the exact same blood sugar level control, and you probably wouldn't be super worried. However, if you're tracking blood sugar levels as well, then you would know the full story, and you can see that A1, the person who's A1, has much more erratic blood sugar levels, and control's not as good as the person who's A2. And so that's why we want to measure not only HbA1c, but blood sugar levels quite a few times a day. So we measure the ones the big ticket ones that we want to measure would be the fasting in the morning, then before every meal, breakfast, lunch, and dinner, and then sometimes before going to bed as well. That will tell you quite a big part of the story, more so than just a simple, HbA1c single number ever can. And so those two are best friends. And if you do HbA1c, you've got to tack on the BSL. Okay, there, I've made my point. Okay, some complications of this when we're trying to manage these levels is hypoglycemia. This is a blood sugar level of less than 4. And what you want to know about this is, do they have awareness? Do they have any symptoms? Do they feel dizzy, lightheaded, etc. when their blood sugar level dips below this number? If it doesn't, it's actually quite dangerous because they could be hypoglycemic and not even know it. And how we manage this is to eat something sweet, such as a jelly bean. And so when you're giving your management plan to the patient, you want to explain that, if you are feeling those symptoms of hypoglycemia, and again, if you've forgotten them, just go and read them up and revise on that. Please eat something sweet, whether it's jelly bean, a piece of chocolate, something, and keep it with you, keep it in your purse, keep it somewhere as you go around and into the world. Particularly if they're on an insulin or a sulfonylurea, because these typically can cause hypoglycemia. Normally metformin and some of the other medications wouldn't cause a hypo on their own, but we'll talk about that in a sec. The other extreme is if their sugars are too high, so hyperglycemia. And as we all know, this comes in two flavors. HHS, which is hyperosmolar hyperglycemic state, is more common in type 2 diabetics. This is where your blood sugar levels are very, very high and your ketones are not really part of the picture here. This normally takes days to develop. It's quite a slow process. Okay. Compare that to DKA, diabetic ketoacidosis, where your sugars are high-ish, but it's really you have massive ketone that's causing huge acidosis. This is more common in type 1, and it's typically more acute than HHS as well. It would develop over the span of hours rather than days. But you can get crossover. So type 2 diabetics can sometimes get DKA, type 1 sometimes can get HHS. It's just less common. So I just want you to know that in terms of the complications when you're thinking about safety netting and management for patients. The other complications of diabetes, we all know about this, so I won't labor this point, other than to say neuropathy is not just peripheral neuropathy, it's also autonomic neuropathy, and that includes gastroparesis, postural hypotension, and erectile dysfunction as well. Okay, so oral hypoglycemics, this is going to be a scary slide. I don't want you to cry yourself to sleep over this, but we'll just go over it quickly. Metformin commonly causes diarrhea, but it really does help with losing weight as well, which often is a really big plus. What I want you to know is there's a risk of acidosis if you give it in someone who's really renally impaired, and so we dose reduce it for renal function, and we don't give metformin if the eGFR is less than 30. The other common medications that I think you should know are probably these three: the GLP-1 agonists, which are actually usually once weekly injections, are not really oral, DPP-4 inhibitors, and your SGLT2 inhibitors. I'm so sorry, they're just like letters and numbers, but this is what it is. The GLP-1s and the SGLT2s are CVD protective, and they help with weight loss. So these are great. We love them, and we give them increasingly more and more. They're kind of in fashion these days. Comparing to these ones, which have fallen out of fashion, including sulfonylureas, which can cause hypoglycemia. So you won't see these used as much, but just know they exist. You don't need to memorize this whole slide, but just know the basics here. Okay, so that's all about diabetes. I'm sorry if that was a bit of a whirlwind, but I think practicing how to communicate that will be a really helpful thing, because things like cardiovascular disease risk and diabetes are quite abstract concepts, and being able to articulate that is important. Let's talk about asthma. What I want you to know about asthma is we can grade people's control, whether they've had good control, partial control, or poor control. You can find it in the Asthma Action Handbook, but I've also given you my summary here. And what we're concerned about, or what we're asking, is how often people have daytime symptoms, and whether that's more than 3 days a week, how often they need their Ventolin, whether that's, again, more than 3 days a week, whether they're having any limitation on their day-to-day activities, and whether they're having any symptoms overnight or when they wake up. And this will grade them as either good, partial, or poor control. This is important because this is actually going to guide our management plan for them. How we manage, so we start by creating an asthma action plan. I think we would all know something about this, but we'll just revise that if we don't. Lifestyle, so SNAP, but particularly paying attention to smoking cessation. We'd also want vaccines, pneumococcal, COVID, influenza, and we'd want them to avoid triggers, whatever the triggers are for them, particularly, whether that's, pet fur or cold air or NSAIDs or whatever it is. Inhalers. So we would start everyone on a SABA, which is short acting, and then we would take a stepwise approach essentially. And if that's not enough, so we would tack on an ICS, an inhaled corticosteroid, and that which is called a preventer. If that's not enough, then we would combine that with a LABA, and then increase the dose of that if we need to. And then if that's not enough, we would refer to respiratory and maybe start something like prednisolone or some other treatment. We would never use LABA monotherapy in asthma. It can be quite dangerous. So make sure if you're treating asthma, you give LABA alongside an ICS and not LABA alone. Now, we don't want to overload people with inhalers. And so if possible, if they're having good control, and remember, we've just defined what good control means, then we can step them down if they've been having good control for 2 or 3 months. First aid is a really important thing to communicate and give to patients because it really is important for their own safety, and it empowers them in that way. 4 puffs, 4 breaths after each, repeat every 4 minutes. Again, I think we should know this. And if they're unresponsive after doing this whole thing twice, then it's an emergency and we'll send them straight to ED, call an ambulance. This is from the asthma handbook. It's the exact same information that I've just given you verbally and in text form, but it's a bit more visual for those of us who are a bit more visual. And if you follow the numbers, it's the exact same progression. You start with a SABA, tack on an ICS, tack on a LABA, increase the dose of the LABA, and then you go into other treatments. This is an asthma action plan. It just tells you what to do when you're well, when you're not well, and if things are getting really dire or it's falling into an emergency. Okay, asthma's evil cousin COPD. Let's talk about that. Similarly to, there's a lot of similarities with asthma. We can classify COPD as mild, moderate, or severe. And I want you to pay attention to the first couple dot points under typical symptoms. So for mild, we're expecting few symptoms, only breathless with like moderate exertion. For moderate, we're expecting breathless walking on level ground and increasing limitation of your ADLs. And for severe, we're expecting breathless on minimal exertion and your daily activities are quite severely curtailed. The other thing I want you to memorize is your FEV1 ranges for mild, moderate, and severe. Very easy kind of thing to slide into an OSCE, slide into an EMQ, and it's a very useful skill if you're able to differentiate mild, moderate, severe in this way. There's also a COPD action plan, which people don't know about, but we'll talk about that as well. So you want to create one of those for someone who has just come in with COPD. Again, SNAP and particularly smoking cessation plus, big time, because we know that smoking pretty much causes COPD. Vaccines are huge as well. Again, pneumococcal, COVID, and influenza. And then we can also send them to pulmonary rehab if they'd like. Similar stepwise approach for inhalers, it's just a little bit different. A SABA or a SAMA to begin, then a LABA or a LAMA, and then we combine a LABA and a LAMA, not if they have coexisting asthma, because we never give LABA monotherapy in asthma. And then we tack on an ICS. We'd only tack on the ICS if the FEV1 is less than 50%, or if they've had 2 exacerbations in the last 12 months. That's the normal criteria for doing that. And I'm assuming we'd all be familiar with these acronyms I'm throwing around, like SABA, which is short-acting beta-2 agonist, and so on, given that this is third-year material. But if let me know if not, and we can quickly go over it. This is pretty much that same info given in visual format from the Lung Foundation. I think it's useful to have a quick look over and just familiarize yourself. And again, we're thinking broadly in terms of mild, moderate, and severe, and what our management would be in all of those cases. This is a COPD action plan, and you can see it looks very, very similar to an asthma action plan, and it's really the exact same approach. So this is really an important thing to do with patients and to give to patients when they've been given this diagnosis. Okay, before we get into prevention, any questions, comments, queries, emotions? Someone's asked, would you ever combine SABA and a SAMA? Good question. I don't know the answer to that from the top of my head. I'll have to get back to you on that. Anyone else have questions? Feel free to unmute or feel free to put it in the chat and we can quickly talk about that before we jump into prevention. I'll just give it 10 seconds maybe. Okay, Oprah's waiting, so we better press on. Okay, we'll talk about prevention now. So some different things. Behavioral change. So the principles of behavioral change we would know from first year stuff, but this is the 5 A's of smoking cessation and the 5 A's of pretty much any behavioral change. We start by asking, and that basically means taking a history of their behavior. Then we advise and say, actually this behavior can be quite harmful for your health for XYZ reasons. Then we assess where they are on their pathway to change and whether they're willing to quit. So this is where we think about the Prochaska and DiClemente cycle and where along that they might be. Then we assist them in creating a plan or a goal, and why not make it a SMART goal while you're at it, to help them cut down on smoking or whatever their behavior is. And then finally we would arrange and say, I'd like to see you again in 2 weeks time or whatever it is. It's quite an arbitrary time period again. So this is the approach you'd take. Again, I would know this, and it might sound silly just going through it like this, but it can very easily be an OSCE station or even half an OSCE station to do this in like 4 minutes after you've taken, I don't know, respiratory history or something like that, or an examination. And so just be comfortable with doing this and be comfortable with communicating in an open way, in a way that empowers the patient, etc., etc. Patient-centered care, right? So if you have ways to show that in an OSCE, I think it's really helpful, and you can practice this with your friends. So please do. Okay, there's some pharmacological management if behavioral change principles are not enough. So firstly, we have nicotine replacement therapy, and the criteria for starting this are if someone is having at least 10 cigs a day, or if they're smoking within half an hour of waking up. We can give nicotine in many modalities. Patches are most common. If you want to do this therapy, you have to quit. So you have to quit, smoking, because we're now pumping nicotine into your system, right? And then you continue nicotine replacement therapy for 12 weeks. The downsides or risks are that it does tend to lead to weight gain, and it does increase your risk of cardiovascular disease, given that we're literally putting nicotine in your body. However, on the plus side, it tends to, the evidence shows that it somewhere between, it doubles quit rates. So from that point of view, it's quite good. An alternative, or if that doesn't work, is oral medications. And this is where people can continue smoking and then quit about 2 weeks into the therapy. There's a few things that we can do. Varenicline or Champix is the most common one that you'll see used, and that's a nicotine partial agonist. And you'll learn more about some of these other ones in psychiatry, so I won't go into them in much detail. But just know that obviously all medications, including these ones, have side effects. Okay, alcohol cessation, so same, 5 A's, and if that doesn't work, we'll get into farm management. So someone who's been abusing alcohol typically is deplete in their vitamins and nourishment. So we want to give them oral multivitamins, make sure they're eating, and particularly want to give them thiamine to avoid Wernicke-Korsakoff syndrome. Again, you'll go into this in psychiatry. Then in terms of farm management, I think about my friend Dan. No, not this Dan. I'm talking about the other Dan, disulfiram, acamprosate, and naltrexone, very iconic trio, that we can give one of these for alcohol cessation. And so they work in all different ways. Disulfiram prevents your body from breaking down alcohol, and so it can actually be quite dangerous if someone like just has this medication and then has a whole bottle of vodka, for example. So you need abstinence for that. Acamprosate, so this stops symptoms of withdrawal. And naltrexone, this is an opioid receptor antagonist, and so it blocks the sense of pleasure when you're drinking alcohol. So all of these things can help on the pathway to recovery. Okay, so now let's talk about screening. So screening for okay, sorry, just checking chat. Screening for colorectal cancer. So I mentioned there's big 3 that we do in Australia, and they're colorectal cancer, breast cancer, and cervical cancer. Those are the only cancers that we screen in Australia, because that's what the evidence says is cost effective and good from like a public health perspective. We don't regularly check, prostates, ovaries, any other part of the body, you name it, because it's just not cost effective. So we only stick to those 3. Let's talk about colorectal cancer. 1 in 13 Australians will have it. It's very, very common. It tends to be sporadic, but in 10% of cases, it can be genetic, and it typically tends to be autosomal dominant if it is. Those are some risk factors that we would probably be familiar with. How we screen for this is a 2-yearly fecal occult blood test, or an FOBT. We give this to the 50 to 74-year-old population, everyone in Australia who fits that criteria pretty much. The sensitivity is very shoddy, to be honest. It's not the best. The specificity is okay, but just keep in mind this test is only really looking for the presence of blood, and you can have blood in your stool for all sorts of reasons, and for even common reasons. If you've got hemorrhoids and just some blood from that, that could be picked up on an FOBT, for example. So just take the result of this test with a pinch of salt. If that increased risk of colorectal cancer, and there's a few different reasons where they might be, I don't have that list for you here, but you can read up on it if you're interested, then we'd be giving them regular colonoscopies. If they're a moderate risk, then we'd be doing that every 5 years from the age of 50. And there is a bit of fine print there as well. And if they're high risk, we would refer straight to gastroenterology because it's too complex for us to manage. And of course, we diagnose with a colonoscopy or a sigmoidoscopy, as we know, and that allows us to go in and take a biopsy and go out. But no one enjoys this procedure, and so but it's something that unfortunately just has to be done. Okay, let's talk about breast cancer. Even more common, 1 in 8 women, and I'd be surprised if you don't know someone who has been affected by this. These are the risk factors. It includes the risk factors includes anyone who's had an increased exposure to estrogen for whatever reason, and such as early menarche, late menopause. Interestingly enough, breastfeeding is a protective factor. People who have BRCA1 or BRCA2 mutations are at higher risk, and I've given you a little bit of reading and some numbers about that. But most people don't have these, and we don't regularly, I guess, screen for these mutations because it is quite expensive. How we screen for it, of course, is a mammogram every 2 years. A mammogram is just a fancy word for a breast X-ray, and so this is what's done, is shown in the image here. It can be a little bit uncomfortable, like it presses on the breast and so on, but to be honest, it's worth it if it can pick up, a breast cancer early. All females from the age of 40 to 74 are eligible for mammograms under Medicare every 2 years for free. However, only 50 to 74-year-olds will actually be formally invited, by a letter from the government, and so that's just worth knowing. The sensitivity is good-ish, can still miss some breast cancers, but it's not too bad. Specificity is pretty low on its own, so we don't normally just do a mammogram on its own. As we know, we would do a triple assessment, so examination, imaging, and biopsy. For imaging, mammogram is your go-to if they're more than 40 years old, and that's when screening also can start. So that's not a coincidence, that's the reason. And that's some things we might see on a mammogram. But it's important to know mammograms are very unreliable for those who are under the age of 40, because the breast tissue tends to be a little bit denser, and hence there's a lot of false positives. And so in this case, we would do an ultrasound instead. The best imaging test would be an MRI, but that's obviously way too expensive and we can't do that for everyone. And then in terms of biopsy, we would take a core biopsy and do microscopy, and then see the immunofluorescence and see what receptors that the cancer has. So that's all for breast cancer. And now we're going to get into cervical cancer, which I feel like the world of cervical cancer and the world of gynecology in general is like big and broad and vast. But so just let's persevere, and we'll try and get through this together. Okay, so infection with HPV, let's start there. HPV is human papillomavirus, and there's many different types of HPV. It's a sexually transmitted infection, but it also causes warts, so it's also a common derm thing. In terms of cervical cancer, HPV 16 and 18 are the high-risk ones that represent the vast majority of cases. However, there are other subtypes of HPV that can also cause cervical cancer. It's just less common and less risk. HPV infections tend to resolve in 1 or 2 years for the majority of people. If it doesn't resolve, then it'll take a decade or 2 to progress to cervical cancer, potentially. Quite a long period of time. And so, these are really slow developing cancers as a general rule. The risk factors, so since it is a sexually transmitted infection, is sexual activity, and the vast majority of people who are sexually active will be exposed to HPV over the course of their life, male, female, all of us. And there's some other risk factors there. One preventative measure is the Gardasil vaccine, and so this vaccinates against HPV 16, 18, and a bunch of other subtypes. It's given as 2 doses, 6 or 12 months apart in primary school, to girls as well as boys. So if you're a domestic student, you probably will have received this. Oh my God, I'm so sorry for giving you this, but I think it's useful to get familiar with some of the lingo of cervical cancer. And there's benign and malignant. CIN or SIN or SIL are used to discuss cervical cancer occurring at the cervix, okay, which can progress to squamous cell carcinoma. Compare this to ASIS, which is an adenocarcinoma that occurs in the endocervix rather than the ectocervix. So there is a difference there. I think having a look at this diagram will be useful to just categorize what all the different types of dysplasia are in terms of how they're graded. And can you believe it? That was just the context of cervical cancer, because it's only now that we're going to discuss the actual screening. So to screen for cervical cancer, we need to do a cervical screening test, or a CST. We do this for all 25 to 74-year-olds every 5 years. Or if they have symptoms, so symptoms like pervaginal bleeding or discharge, itchiness, anything suspicious like that, then we might do kind of PRN, I guess, on demand. Every CST, what it involves is a speculum being inserted into the vagina, and then just this brush that goes in and just gets a sample of fluid and cells from the cervix. Now, what happens to that sample? We send it to pathology, and the pathologists do PCR, so polymerase chain reaction, to check for the presence of HPV. If it's positive for any HPV, then they'll do liquid-based cytology to actually look under the microscope and see what's going on. This is very important, very high yield, so please pay attention at this moment, because this tells us what we're going to do based on the results of this test. People are considered low risk if they have no HPV identified on PCR. And in that case, we would just go to screening with CST every 5 years as normal. So that's fine. People are considered intermediate risk if they have an other HPV result. And by that, we mean not HPV 16 or 18, but one of the other 12 subtypes for the first time. So only if they've had this result for the first time, then we would repeat again in 12 months' time. People are considered high risk for one of 3 reasons. If they have HPV 16 or 18 identified, if they have an other HPV identified for the second time, so they were previously had an other HPV, we did it again in 12 months, and it's still there, then we'd consider it to be high risk, or if they have high-grade changes on liquid-based cytology. Okay, all of these people would be considered high risk, and in that case, we would do urgent colposcopy to further investigate that. The sensitivity is reasonably good, but HPV can be undetectable in the first 8 months of infection. The specificity is really, really good because we're doing a very specific test to look for the presence of HPV and then liquid-based cytology to actually look at the cells. So it is quite specific. An alternative is a self-collected high vaginal swab, which is still quite sensitive, but they're going to need a speculum anyway if they're positive. So to be honest, you're better off just doing a CST if you can convince them to do that. It probably makes more sense. And how we diagnose if we need to do this is with a colposcopy. So we actually go in and take a biopsy, and we can do things with vinegar and iodine and stuff to see if there's color changes, and that gives us information to tell us if it's malignant or not. So that's what we would do with cervical cancer, and that's our progression of how we deal with screening. And this has changed recently in the last, I think, 2 or 3 years. And so this is quite a hot topic, and I would know this in good detail. I know it was a little bit confusing when I talked about low, intermediate, and high. And so this is just the same thing in visual format, if this makes more sense to you. But please do learn this because it is high yield for both for ONG as well as for GP. Okay, so we can get into OSCEs. I'm just going to see if anyone has any questions, comments, queries, emotions. Someone's asking, why is LABA monotherapy dangerous? I don't actually know the answer to that question. I'll have to read up on that and get back to you. I just know that it is dangerous. Any other questions? Someone's asking me what's second line after metformin in type 2 diabetes, and when would we involve endocrinology in managing? Oh, I love this question. Okay, second line after metformin would be, depends. There's no right answer to that, but usually would be one of those other 3 medications I mentioned after metformin. But it depends on the clinician, depends what they're using. We used to use things like sulfonylurea second line, but we don't tend to do that as often because of the hypo risk. When would you involve endocrinology in managing diabetes? If it's really severe, if they have a lot of complications, if we're worried about the patient in any of those ways. Otherwise, you can normally manage type 2 diabetes in the primary care setting, to be honest. Someone else is asking, are there other reasons a person can be mod to high risk? For what topic? Oh, for HPV, okay. E.g. family history, even though 90% plus are caused by HPV. So getting back to cervical, sorry, I'm just trying to make sense of the question. Are there other reasons a person can be mod to high risk? To my understanding, this was normally the flowchart and the way we go about it. Yes, there are other risk factors, but in terms of low, intermediate, and high risk in this context of CST screening and what we do for the patient in this setting, we tend to follow this. Perhaps there are cases where people are really high risk at baseline, and hence we might just do much more regular testing. I don't know, and I don't think you need to know that as a GP or at this stage anyway. That gets probably more into gynae stuff. Another question. Okay, so someone's schooling me here, so I like this. So they're explaining why we don't use LABA monotherapy in asthma. The onset of most LABAs takes time, as well as they don't act to stop the inflammatory reaction, which is thought to be more important in asthma than COPD. Yes, asthma is primarily inflammatory as compared to COPD. Okay, so that's why we do it. Someone's asking me where the CST flowchart is from. Good question. I don't have an answer from the top of my head. I can easily look that up. I can have that answer to you by today. Okay. Rapid fire questions. I think let's press on in the interest of finishing up. OSCEs, so I'm just looking at time, and Bridget, there's only 3 OSCEs here, and we're just gonna talk through it as a group. So we'll just speed through this. I just want us to think about this. So you're a GP seeing Mark, a 70-year-old man who's been complaining of dyspnea and chronic cough for 2 months, background of smoking nicotine for 37 years, quite a long time. You conclude that he's developed COPD. His FEV1 is 75% of his predicted FEV1, and please provide him this diagnosis and management plan. So this is a very typical kind of OSCE station you can get, is to do that 10 steps or 11 steps of management in the 8 minutes that you've been given for an OSCE. I want you to actually do this in your own time with a friend. Okay, but I'm just going to give you some thoughts and I guess pointers to point you in the direction of, if you want to do really well in ACEs, what I think you should be thinking about. So this patient clearly needs health education and a guided push towards smoking cessation, because they probably don't necessarily know the proper link between the smoking and their symptoms, or they might vaguely know but not really recognize it. So a strong candidate would explain what COPD is, not in complex language, just in basic patient-friendly terms, outline the complications, so why should they be worried about it, encourage smoking cessation, and if the focus of the station is not on smoking cessation, then the patient will say, oh yeah, I'm thinking about smoking cessation, but maybe we can talk about it later, or something like that, in which case you can say, yeah, sure, we'll talk about it in our next consult. And that's a common way sometimes in OSCEs that's communicated to you, that you shouldn't be stressing about this because there's not really many points allocated to it. But that varies station to station. And then vaccines, flu, pneumococcal, COVID, start Ventolin, mention a COPD action plan. And then the other thing, which I haven't written there, is explain basic first aid and when they should come to the ED. So it's quite a lot of ground to cover, to be honest, in 8 minutes. So you really do need to be time efficient if you want to score really well. Second one, you're a GP doing a routine checkup for Phil, a 58-year-old man. You notice his HbA1c has come back as 7.4%. He has no history other than father having type 2 diabetes, so he reports no symptoms. Please communicate your diagnosis and management plan to the patient. Okay, so this is probably type 2 diabetes, and we talked about this in some detail, and again, I want you to do this in your own time, but I think it's deceptively simple, and it's easy to get complacent. But if you want to do really well, here's how I would take it to the next level. Patient's asymptomatic and probably has no reason to feel worried or afraid about what's happening. So you need to explain what type 2 diabetes is in a way that makes sense. Highlight the complications, and there's so many complications that we talked about. So actually give them some sort of reason to be worried and concerned, and actually want to do something about this to prevent all those complications. Outline the SNAP management that you should all be familiar with. Blood sugar level monitoring, you probably would want to start metformin. Screen for type 1, even though this is probably type 2, just looking at this scenario, you can still just tack that in. And then safety net for all the complications of diabetes, the many complications that we know about. So again, a lot of ground to cover in 8 minutes, I think. So please do practice. And last one, we'll just talk about this. You're a GP looking after Angela, 17-year-old with lesions suggestive of acne. She's distressed about the appearance of these lesions. Provide her this diagnosis and this broad management plan. Okay, I feel like this is a little bit more left of field, given that acne is A common condition, but has not really been the focus, I think, as much. But I think it's still a very fair auscultation to get. My thoughts on this. So this is actually very different to the previous case because this patient is already super anxious about their condition. So we're going to have to communicate in a different way. To do well, you need to explain the origins of acne in very simple language, and please practice how to do this. It's not easy. Dispel the common myths. It's not chocolate that causes it. Reiterate that's very common in your age group. Give the broad, very broad management principles, basic skincare, basic topical therapy you might start. I think you should screen for PCOS given the patient's age demographic, and then definitely offer psychological support. Be the holistic GP. Don't be the GP who just sees acne. You need to see the whole patient. And clearly this is a patient who is very concerned and might either just want to have a chat to you as the GP, or get some sort of other counseling or help from a psychologist. So definitely offer that and make clear that that help is available should the patient desire it. Okay,